Hi guys, let's finish up dissecting aneurysms today. And this is a lecture I threw up on YouTube. You're furiously studying for your CCP exams tomorrow, so cut you a little bit of slack. But make sure you watch this video because it will be on the test. This is for fall. It's Thursday. It's week 4. Here we go. So let's remember where we were. We were talking about dissecting aneurysms. And we said these are usually false aneurysms because a false aneurysm starts with a tear in the tunica intima, the inner part of an artery. And we're really talking about the high pressure aorta here. Most commonly it's the ascending aorta, then we have the aortic arch and the descending aorta. This cartoon that's occurred in the proximal descending aorta may have started as a true or a false aneurysm. And then what happens is the blood, instead of ripping right completely through the aorta, it encounters that external elastic laminae, that extra tough sheet, and oftentimes it finds it's pretty tough to get through there. So it finds it easier to rip down through the tunica media. Usually follows the flow of blood down. So remember, this is called the false lumen. This is called the true lumen. And as the false lumen fills with blood and it starts to clot and you get hematomas in here, it pushes further and further into the true lumen and you start to get a beaver dam here. Right? You start to get decreased blood flow from the beaver dam. And let me try my new drawing tools here too. See how they work. So as this starts to get bigger and bigger here, we got ourselves a beaver dam here. And so you have decreased blood flow here and decreased blood pressure and increased pressure up here. And that increased pressure up here transmits into the arteries, right? You got your left subclavian right here, so all the pulses, and there's your common carotid, so your carotid pulse is strong. All the pulses in your extremity are strong because of this beaver dam phenomenon here. And then we said eventually most of these dissecting aneurysms will eventually rip open here. And all these blood clots will be released. And downstream they go, and who knows where they'll get stuck. I asked the question in class, let's see if you do any better now. Could you possibly get a stroke from this situation? No, because the blood flow is like this. Right? The clot's going to go downstream. That's called the embolism. It's going to go downstream. It's not going to go back upstream, go up the common carotid and in the internal carotid and get up into your noodle up in the circle of Willis. No. But if it happened over here and one was released, then yes, there's a possibility it could go up. Brachycephalic trunk and into the right common carotid, into the right internal carotid, and into the circle of Willis, and it'll get stuck there because those vessels are small. Alright, so we covered that yesterday. It's nice to be able to draw too. Let's see, now why are we stuck? There we go. And there's just the phenomenon of double barrowing, which I just drew. So those embolisms will go downstream. All right, this is where we stopped, so this is new material. So we said most of the time it starts from a true aneurysm or from a false aneurysm, but sometimes you can get a hemorrhage or an aneurysm which pops or hemorrhages of the vasorum. And we said there's blood vessels, there's arteries and veins in the big aorta that give life to the cells in the outer one half. And if that pops, the blood will start to accumulate and that can rip its way down. And so that's another way, that's a vasovasorum dissecting aneurysm. That's another way. That kind tends to happen in the carotid arteries and in the vertebral artery. That's the most common in that region. It's not that common in the aorta, though. Okay. So that's pretty straightforward. Just in general, what are the risk factors for any type of dissecting aneurysm? Well, anything that weakens or disturbs the architecture of the wall that contains the pressurized blood. So the hereditary conditions, the usual suspects, the connective tissue disorders that you're born with. You got Marfan syndrome, Louis-Dietz, Ehlers-Danlos, neurofibromatosis 1 can all present with weak tissue, weak arterial walls, and they're prone to aneurysm and rupture. Blunt chest trauma from hitting the steering wheel, for example, in a motor vehicle accident. Iatrogenic, you could get stabbed. An artery could get stabbed and then heal, and the scar tissue would be weak from that. Or from a catheter, you could get stabbed from the inside. And then false aneurysms, which we've already talked about. Smokers are notorious for developing these. That's a high risk factor for these in older men in particular, especially if they have hypertension. These are the two strongest risk factors. Previous infection, so having a history of some vasculitis that affected the aorta, probably staph or strep or some other bug. Some demographics. So these usually happen in older people over the age of 50. They almost always have antecedent hypertension. Add that to your vocabulary list. If you don't know what antecedent means, that means pre-existing. In fact, some research shows 80% of all cases of dissections are in people with pre-existing hypertension. Years and years of high pressure just weakens the blood vessel walls. And then, surprisingly, there's a young group as well, but these are the ones that have the connective tissue disorders, Marfan's, Louis-Dietz, neurofibromatosis 1, Ehlers-Danlos. The ascending aorta dissections, well, the majority of them occur here, and that's no surprise because that's where the high pressure is, right? That's where the pressure is coming full power right out of the left ventricle. So that's the most common place for a dissection is in the ascending part of the aorta. And if that, as we already said, if that double barrels, you definitely have a chance of having a stroke. We already explained that. Right? And so again, I guess I can do my drawing tools again. So if you get a dissection, let's say it's right here. There's tunica media, we'll say right here's the dissection that occurs. And when it double barrels back in, it throws out some embolisms. It all depends on the luck of where the river takes it. Some of them might go all the way around the horn here, go down, get stuck in your foot. If you're unlucky, one will go right up this brachiocephalic trunk. And then if you're more unlucky, it goes in the right common carotid, and then it can go right up into the brain here. Not a very good brain drawer, but yep, it can go up into there into the circle of Willis, and now you have yourself a stroke. Note that AKA for brachiocephalic trunk, the innominate artery. Watch out for that one. Concept of a retrograde dissection. So a retrograde dissection, I don't know if I can draw this very good or not. Let's say this is that's the tunica intima right here. We'll draw this tunica intima. And let's say we have a crack occurs here and the blood flow, let's see, we'll make this Mr. Spock, green blood. So the blood gets in here and has nowhere to go. It can't get through the outer part here. Most of the time it would go downstream, but sometimes, for reasons not really understood, it can rip down the tunica media kind of against the flow of the blood. Remember, the flow of the blood is that way. Okay, so that's called a retrograde dissection. And it can go back, and you have the aortic valves here, right? The 3 aortic valves. And it can rip right into the one or both of the or two of the cusps and wreck it to the point it doesn't work anymore. And we know during systole, blood flows, or during diastole, blood flows backwards that way. And if the cusp is broken, you can get blood flow back into your heart. And we're going to talk about that. That's called aortic regurgitation. But that stems from a dissection that goes backwards, or retrograde dissection. The other thing we should say while I'm here drawing, let's go back to blue. I think that's number 2. We also have the pericardial sac is connected in here, right? That surrounds the heart. And so if you do spring a leak, because what happens here, what if some of the blood starts leaking out? The blood can accumulate around the heart in the pericardial cavity, and it can go all the way around the heart. And it can start to squish the heart so you don't get good blood flow out of the heart. So that's called cardiac tamponade. So these retrograde dissections, no good. All right. So everything I just said, retrograde dissection, that's where it goes backwards, and it can cause cardiac tamponade, if we just said, and we just did talk about it, but we'll talk about it a little more in a while. What about other locations? They can occur. They don't all occur in the ascending aorta. They can occur in the descending thoracic aorta. They can occur in the aortic arch, in the abdominal aorta, about 5% of the time. The higher the blood pressure in that part of the vessel, the greater the chances there are for a dissection. If it ruptures, what if it ruptures? Well, you're in big trouble, especially if it's the ascending aorta. I mean, it's high pressure, right? It's 120 millimeters of pressure. Blood will come gushing out of that, and your pressure will drop like a rock, and you can go into hypovolemic shock because you don't have enough blood running around, and your liver and your organs can die quite quickly in that scenario. All right, let's see. Yep, everything we said. Slip into hypovolemic shock and you can die quickly. Let's see. Again, if the retrograde dissection occurs, complications can occur. We said we could wreck the aortic valve and get regurgitation. We'll see the sequelae of that in a minute. Cardiac tamponade, if the pericardial cavity fills up with blood, or aortic regurgitation in and of itself will cause heart failure, eventual heart failure. We'll look at that mechanism real quick. What's the gold standard for making the diagnosis? How do you diagnose a dissection? It's a CT with contrast is what you do. Some call it an arteriogram, but CT contrast can do the trick. MRI is the second best thing, then third place is an ultrasound. Morbidity and mortality. What's the chances of dying from this thing? Well, the farther it is, the more high pressure that the vessel is, the greater your chances of dying. So Stanford A, we haven't got to those yet. We'll talk about those in a second. But dissections that occur in that ascending aorta have much greater morbidity and mortality. In fact, let's talk about these classifications. High yield board stuff, you got to know these things. We have the Stanford system and the DeBakey system are the big ones you have to know. So let's take a look at them. Stanford first. Sometimes they're just called Type A dissections. Usually called a Stanford A, but you never know. If you see just a Type A dissection, it's understood that they're talking about a Stanford A dissection. And here's the rule. It must involve the ascending aorta only. Or not only, but it has to involve the ascending aorta. Part 2 of the rule, it could also involve another part of the aorta, but it may not. So as long as it's in the ascending aorta, it's a Stanford A. If the dissection goes into the aortic arch, and what are these? And I shouldn't have to go over this, but this is going on YouTube. Maybe some of you don't know the parts. So the heart would be right here. It's kind of a silly heart, but left ventricle is squeezing blood out. So the ascending aorta is from here to here. Ascending aorta from here to here. This is the aortic arch, and this is the descending aorta. Thoracic, once it passes through the diaphragm, it becomes the abdominal aorta. Okay. All right. So Stanford A again, it has to involve. I'm really liking these pens. I wish I could turn them on easier, though I have to go down there and physically click on them. So it has to involve this region. That's a Stanford A. If it goes into here, well, great, still a Stanford A. Maybe it didn't go into here. Maybe it reappears over here. Stanford A. Maybe it didn't go there. Maybe it appeared down here. Stanford A. As the rule is, this has to be there. And if that's the only thing, that's the only part, that's still a Stanford A. Got it? Okay. Right. These are the most common because the pressure is the highest. These also include a little more precise naming system. DeBakey 1 and DeBakey 2 are both members of this system. All right. So everything I said. Let's look at Stanford B. So the rule, it must not involve the ascending aorta. So if you have a dissection that starts in the arch, which is kind of unlikely, but it could, Stanford B. If it just starts in a little piece here, the descending thoracic aorta, Stanford B. If it starts down here in the abdominal aorta, Stanford B. The rule is any aneurysm in the aorta, but it can't involve the ascending aorta, is a Stanford B. Got it? Pretty straightforward. Now, the DeBakey system, this is for chiropractors. This will probably be more likely to be on boards because Robbins is a board book. It's a little bit more precise. So DeBakey 1, 2, and 3. DeBakey 1, the rule says the dissection, there must be a dissection in the ascending aorta. And the second part of that rule says it must progress. So it's got to go into another part of the aorta as well. Usually the aortic arch. Okay, it may even go into the descending aorta. So it's usually a very dangerous type of dissection, right? But it has to be the ascending aorta and more. DeBakey 2, the rule says it can only involve the ascending aorta. And of all the systems, this is the only one that says it can only involve the ascending aorta. Right? If it involves the ascending aorta and it shows up in the descending aorta somewhere, it's not a DeBakey 2. That would be a DeBakey 1. This has to be isolated to the ascending aorta. Very dangerous again. DeBakey 3 rule says it can only be in the descending aorta. Simple as that. So it can't be in the arch, it can't be in the ascending aorta. Right? The hole in this classification system, what happens if you get a dissection that's only in the aortic arch? There's no designation for that one. So that's a problem with it. All right, so DeBakey 1 must be here in the ascending aorta, and it must be at least into the aortic arch, or at least it must be somewhere else. If it's only in the ascending aorta, it's a DeBakey 2. If it shows up anywhere in the descending aorta, it doesn't have to be this whole thing either, right? It could be just a little piece of it. but that's DeBakey 3. Okay, just a side note, these systems are oversimplified. They're really for students. They're not for vascular surgeons. Vascular surgeons use a system called the Landsman classification system, but that's way beyond the scope of this lecture and the scope of boards for medical students and chiropractic students. What about epidemiology? The incidence of aortic dissections has been calculated to be about 0.3% of the population, so it's rare. It's not crazy rare. It's not like Marfan syndrome. Of that 0.3%, about 2% of those are serious, significant dissections that often end in death. In 2011, there was about 10,000 cases in the United States, which that's a lot, but it's not millions of cases. Females tend to be more affected than males. We're not quite sure why that is. Let's see, ascending aorta affected mortality rate. Yeah, we said it's bad, right? The most common place to get one of these is in the ascending aorta, and it's bad news. Very dangerous. Look at this mortality rate. So without treatment, mortality rate for a Stanford A or a DeBakey 1 or 2, i.e. for an aneurysm for a dissecting aneurysm in the ascending part of the aorta, 1% die per hour. So by the end of day 2, 50% of people will be dead from this. By the end of day 14, 18% will be dead. That's actually should be, is that without? Yeah, that's true. That's without treatment. Because they can cut the pipe out and put a new pipe in there. That Dacron, we talked about Dacron graft repairs. That's dangerous, but yeah, without treatment, it's quite dangerous. Stanford B, so that's just in the descending aorta. That's not nearly as bad. The 30-day mortality rate's under 10%. As long as there's no complications, if you get a retrograde dissection. But that wouldn't be a Stanford B, though. So if you have aortic stenosis, you just happen to have that, or any other valve problems. If the aorta ruptures, of course, then all bets are off. Most of the time it's Stanford B, it's not that bad. Or DeBakey 3. Okay, we said we're going to talk more. We really explained the retrograde dissection, but here it is again. Extremely dangerous. We said the rip can go backwards and disrupt the aortic valve and wreck it. And that can lead to aortic regurgitation, which could be a permanent thing. It could also leak blood into the pericardial cavity, and you could squish your heart. That's called cardiac tamponade, and we'll talk more about that when we get to the heart. Remember the nice picture of the pericardium here. They cut it so you can kind of see through it. But remember, this is welded right here. So this is airtight. It's welded around the roots of these great vessels here. And so if you get a leak in there, get my drawing pen out here. So yeah, if there's a, oh, that wasn't good. If you get a leak, let's say right here, dissection starts bleeding blue blood, it can fill this thing up, right, and get bigger and bigger and bigger, and it can squish the heart, and that's called cardiac tamponade. And here's a cartoon of the cardiac tamponade. We can see how the heart is squeezed. There's many other things that can cause cardiac tamponade. This is a fluid, so you can get pericardial fluid, and we'll talk about that when the time comes. But it could be blood as well. It could be fibrous tissue. There's a bunch of different things that can cause it. It's usually blood or serous fluid that gets in there. And as we said before, there's one functioning valve. This valve is displaced. There's the dissection that went retrograde, and it wrecked that valve. And now we have, on every diastole, we're not supposed to have blood coming in, or all the blood is supposed to be out of the heart, or most of the blood is supposed to be out of the heart. But we have a leaking valve that occurs during diastole. And then we have atrial diastole, and of course during diastole this left ventricle is filling up, but it's got extra blood in it. So what does that mean? Well, atrial systole occurs and squishes more blood in here. So every single heartbeat, this left ventricle is stuffed, just absolutely packed with blood. And is that a good thing? No, it's not a good thing. So I mean, diastole will fill it up maybe about this full. And we got that extra blood. And then there's an atrial systole. Ventricular diastole, the end part of ventricular diastole, there's an atrial systole where the atria contract and fill this up with blood. But now there's too much blood in there. And so the heart is stuffed and stretches. And that's not a good thing. What happens when the heart is overstretched? Yeah, there's an extra strong contraction. Right? So every single heartbeat, you're going to have way too much blood shooting out here. And that's also going to make the carotid arteries bug out. Remember the water hammer pulse. Getting ahead of myself here. But yeah, that's basically where we're going here. So that extra blood, that overstuffs the left ventricle. What's that mean in scientific speak? Preload. You've way increased the preload. And that's the end diastolic pressure is way too high. And the overstretched right ventricle is going to contract more powerfully on every single contraction, according to Starling's law. Okay, simple physiology stuff here. So what's going to happen? Well, if your heart is beating more powerfully on every single heartbeat, it's like a bodybuilder working out. It's going to get really muscular. But bodybuilders know they can't work out hard every day. They have to rest, right, to let their muscles recover. But your heart never rests. So the beautiful muscle is going to turn to fat and fiber and stiff, and it can actually get flabby at the end. So it gets wrecked. And if the left ventricle gets wrecked, your heart is dying. You need your left ventricle to supply blood to your body. And so you get heart failure, or that's known as cardiomyopathy. See how that works. All right, that's kind of everything we said, again, about the aortic regurgitation. Oh, we haven't talked about this, though. There's a beaver dam effect, right? If the heart can't pump blood, then you get a backup of blood. Remember this thing. Remember the beaver dam thing here. Let's see, what color should we make it? I guess we'll keep it red. So if the heart can't pump blood, well, if the heart can't keep up with the demand, and it can't in this situation because it's overfilled with blood and it's starting to fail, then you get a backup of blood. First, it blows up the left atrium, starts to get overstuffed, and that can ruin the mitral valves. So you can get mitral insufficiency. But then the backup, just like a traffic accident, if this is a traffic accident here, and normally the cars would go that way, the cars are going to back up. And the cars back up into the lungs. And so the lungs start getting filled up with blood. In fact, the blood can start spilling into the alveoli, and you can start coughing up a pink frothy sputum. So that's pulmonary hypertension and pulmonary edema. And it goes even further. The backup, just like a major accident, the backup now goes into the right ventricle. And the right heart, which usually has a very easy job, it senses that the left heart is way backed up and it's not doing its job. It can't get blood through the lungs. So it contracts really hard in attempts to fix the situation. The right heart is not designed to contract really hard. So it starts to fail, which worsens the situation. Now the traffic jam goes all the way up into your jugular, your external jugular vein, and your jugular veins start to bug out, especially when you take a deep breath in, right? Take a deep breath in, that sucks blood into the heart. But if you can't get any blood sucking into the heart, it makes your jugular veins bug out when you take a breath, and that's Kussmaul's sign. We'll talk about that more when the time comes. And then the blood backs up into the liver, so your liver starts swelling. and you get hepatomegaly, and we'll teach you how to palpate for that and percuss for a blown up liver. Then the portal vein is affected. The portal vein goes to the spleen. The spleen fills up with blood, and that becomes palpable, which you're not supposed to. We'll talk about Traub space and some ways to look for splenomegaly. And then the intestines, the microcirculation of the intestines start overfilling with fluid, and that fluid doesn't spill inside the intestines, it spills outside the intestines into the peritoneal cavity or peritoneal cavity, tomatoes, and you start to get a belly full of fluid, all from this failing heart. And then finally your ankles start swelling up like crazy because the traffic has made it all the way into your ankles and it can't go any further. Right? So that's the beaver dam story repeated. So make sure you know that. I don't know how many times I think we talked about that at the first lecture, but that's an important concept. All right, aortic regurgitation. Yep. So this, if it's aortic regurgitation that acts as the beaver dam, and the heart fails, it's called valvular cardiomyopathy. Valvular cardiomyopathy. Okay. Fun facts. Might see a water hammer pulse, as we said. We've talked about that before. Throw a few slides on that again. It's so important. Also called the collapsing pulse or the Corrigan's pulse. And as we just said already, the big overstuffed left ventricle blasts too much blood up into the carotid arteries and they bug out like crazy. But when diastole occurs, because those valves are incompetent, that bulge of blood disappears suddenly because it goes back into the heart. So you get this quick bugging out of the carotid arteries, and then they suck back in. So it's I think I gave you a link to a YouTube video on that. You should see that and see what that looks like. It's called a water hammer pulse. More sequelae. How can this cause this regurgitant aortic valve cause even more trouble? Well, you can get coronary artery stenosis. The coronary arteries, which supply the heart with blood, the heart is a living tissue. It's got to have blood too. Where does that blood come from? The coronary artery system. Well, the coronary artery system, the coronary arteries are underneath the serous pericardium. Actually the visceral part of the serous pericardium. It's called the epicardium. And they can get squeezed as the heart muscle gets stronger. Those arteries get squished between the pericardium and the growing myocardium of the heart. And if they get squished, blood has trouble going through them. And therefore your heart tissue starts to die because it's constantly not getting enough blood. And if that kills the heart, it's called ischemic cardiomyopathy. That was a juicy little section, wasn't it? All right, what about the clinical presentation of a type A dissection? We kind of said this already, but a man in his 50s, usually, could be a young kid with Marfan syndrome, but usually it's a man, smoker. He gets ripping, horrible pain in his chest. Sometimes it radiates to the scapula. But here's the way you can tell. It doesn't always occur, but if this happens, it's a dissection. They're laying there in the emergency room, and the pain is right in his sternum, maybe the manubrium. And then every hour it starts moving and moving further to the right, and then it starts to go down his chest. I guess I can draw this now that I'm on YouTube. I have the ability to draw. So let's see. And this is why I don't draw, you'll see. Well, you already saw why I don't draw my last diagrams. So here's the man's chest. He's laying face up. So we'll make his pain red. Make his eyes red too, because he's not feeling good. All right, so he comes in. He's got pain right there in the sternum. But every hour it starts to follow the path of the aorta, and it's going down and down. Now his pain is all the way down his chest. That's a terrible sign. That's a dissecting aneurysm. And it's literally progressing. In hours it can rip all the way down in some people once it gets started. Some people it can take months to rip down. Some people it never rips down. It all depends on how strong that tunica media is. But that ripping, moving, descending pain is a really bad sign. The symptoms can mimic a heart attack. You might come in, think you're having a heart attack, and it's really a dissection. You could have hypertension, tachycardia is very common. You're scared. Sympathetics are flowing, stimulating the heart to beat faster. Maybe there's a false lumen that's crushing the true lumen, and you're ischemic, so your heart's trying to make up for that. If you have hypotension, that's a really bad sign. That means that you've sprung a leak somewhere, and you're in trouble. Let's do a case, and no, we're not quite out of here, but we're almost out of here. 65-year-old, this is a juicy case. 65-year-old, long-time smoker, comes in, moderate pain, cold feet, which is kind of weird, dyspnea, trouble breathing, blood pressure. Well, you tell me, how's that blood pressure look? That's high, right? That's definitely high. So trouble breathing, high blood pressure. I mean, right there, you just send them to the emergency room. But if you want to, you're out in the woods at Alaska and there's no docs around, you can keep doing the workup. You auscultate his heart, you listen to his heart, and everything sounds good. You don't hear a murmur in this case. They do have tachycardia, the heart's going fast. You do an exam of his upper and lower extremities and take the pulses, and you notice that the carotid pulse and the brachial pulse and radial pulse are pounding. They're really high. And you think, well, it's just his heart rate and he's anxiety. But then you take his femoral pulse and popliteal pulse, and you can't even find him. And that's why his feet are cold. He's not getting enough blood. You do Berger's test. It's positive. His feet blanch at 45 degrees. You do an arterial pulse examination. We already said that. Low pulse is -1 on all lower extremities, +3 on all upper extremities. There's no water hammer pulse. What's the diagnosis? Well, you probably know because this is what we've been talking about. But here's the hint. What's that thing? Beaver dam. Yeah, he's got a dissection somewhere, right? He's got a dissection, and you want to see a CT? Now you'll know the story. So here's about T7. Yeah, there's the lumen of the true aorta, thoracic aorta. What's that? That's the false aneurysm. That's the dissection, and it's a big one. It's squished. It's knocked out at least 50% of the blood flow through the regular lumen here. So he's getting ischemia downstream. Why does he have hypertension? Why does he have hypertension? Let's draw this. I'm in a drawing mood today. Got this new laptop too, this XPS 15. The trackpad, I can't use a mouse with my hands. But man, this trackpad is like so smooth, I can draw so much better on this thing. So he's got a beaver dam right here. Right? Beaver dam. Because he's got a dissecting aneurysm. So decreased blood pressure downstream. But remember what's over here in the back more. Right? You got the kidneys over here. So the renal artery is also has decreased blood flow through it. All right. What happens if you have decreased blood flow? Who gets turned on? R2A system is turned on. That's going to cause hypertension via angiotensin II. We've talked about that a zillion times. All right. So that's why he's got hypertension. Yep, I think we got everything already talked about. Coarctation of the aorta could be a differential. We've talked about that several times. That thing you're born with where your tunica media is super thick and it pinches your true lumen down to nothing. but that would be probably in a child though, not an adult. All right, we did it. So good luck on your exam tomorrow. I'll actually see you. I'm doing the testing, the written test part. I'll be kind of hanging out watching you guys. So good luck. See you later. Email me those questions.